I'd like to wish you all a good afternoon, and thank you for joining the last session in the 12th Annual International Dementia Conference 2020. My name is Kim Tully, and I'm the host for the session. I'm the interim CEO while Sinead gets her master's in psychology this year. So it's been a great couple of days. I just want to first of all thank all the panelists that have spoken in all of our sessions, and of course the ones that are going to be in this session that we're going to listen to right now as well. We'd also like to thank our academic partner, Professor Kate Irving at the School of Nursing, Psychotherapy and Community Health at Dublin City University. We'd also like to thank the other members of our conference advisory panel, the HSE National Dementia Office, the Dementia Services Information and Development Centre, Nursing Homes Ireland, the Global Brain Health Institute, the Dementia Research Network of Ireland, and the Alzheimer's Society of Ireland. And a special thanks as well to our sponsor, Home Instead Senior Care, with a particular welcome to Richard Mullins. We'd also like to remind you that even though our conference is over with, there's still a very interesting session tomorrow. You are invited to sign up for the Dementia Research Network of Ireland and National Dementia Office Policy and Practice Forum. You can find the details on our conference page. That's going to be tomorrow afternoon. We also are very proud to announce that Engaging Dementia has been shortlisted for the Irish Charity Impact Award 2020. We would invite you to vote for us. We'd really appreciate it. You can also find the details on our website. So with no further ado, I'd like to start this session now, which is titled Meeting the Needs of People with Intellectual Disability and Dementia. And I'm first going to turn it over to Cathal, but I'll make him visible first before I introduce him.
Hi, everybody.
So I'd like to introduce to you Cathal Blake, PhD candidate at Dublin City University. So Cathal, if you could introduce yourself first and then start your presentation, that'd be great.
Hi, everybody. My name is Cathal Blake, and I am a current PhD student in the School of Psychology in Dublin City University. Now, my research was using the experiences of people with dementia using public transport, and the research supervisor on this was Dr. Louise Hopper. As I've already said, we're from the School of Psychology in Dublin City University, and the research was conducted in conjunction with the Alzheimer's Society of Ireland and the Irish Dementia Working Group. Before I continue into the research, I'd just like to make a few acknowledgements. I'd like to thank the participants and their families for the participation and their openness and honesty during this study. Thanks also has to go to the Alzheimer's Society of Ireland, who funded this study and assisted with participant recruitment. In particular, thanks to Dr. Bernadette Rock, Dr. Laura O'Philbin and Clodagh Whelan from the ASI. And I'd also like to thank Cathy Ryan from the Irish Dementia Working Group. And of course, a special thanks goes to Dr. Louise Hopper from Dublin City University, who supervised me on this project. So a little bit of background first. The Irish Dementia Working Group was established in 2013 and has since grown in both numbers and member capacity. And there's now active groups in eastern, southern and western parts of Ireland. Members of the Southern Dementia Working Group at one of their meetings had raised concerns in relation to the issue of public transport for people with dementia. The group had expressed concerns regarding the lack of public transport, the fear around independence when using this transport, and in particular the worry about what happens when a person can no longer drive and then may be reliant on public transport. So following a discussion, the Irish Dementia Working Group steering group decided to research this particular topic. Specifically, the group would like to explore the experiences of people with dementia have when using public transport. So then the Alzheimer's Society of Ireland came on board and they commissioned the research to investigate how people with dementia experience public transport. The overall aim was to capture these experiences of the Irish Dementia Working Group members as they made a variety of journeys in public transport, but specific objectives were a lit review first on issues of public transport and access for people living with dementia, and then conduct a qualitative analysis of the experiences of people with dementia have when using public transport. And then both 1 and 2 were formulated then in the analysis, and the findings were formulated into a subsequent report and recommendations. So public patient involvement was used in this research. Now, PPI may be defined as research being carried out with or by members of the public rather than to, about or for them. So this is a very good example of PPI, because people living with dementia actually set the research question, they set the agenda and set the topics. PPI allows for public and patients to be involved at every stage of the research, beginning with, as I said, topic selection, study design, and assisting with participant recruitment, all the way through to the final reviewing and dissemination of findings. So the lit review then, it was a scoping lit review that I used to identify any existing literature in the area of people living with dementia and public transport use across all elements of the travel chain. And I'll speak a little bit about the travel chain now in the next couple of slides. The literature search was carried out using a wide range of databases accessible through Web of Science, PsycInfo, Psych articles, but I also looked at grey literature such as government reports and position papers. To be eligible for inclusion, the articles had to be written in English, published in peer-reviewed medical and health, technical or social science journals, and address the issues of cognitive impairments in relation to the use of public transport. Search terms used included cognitive impairment and or dementia, and driving cessation or public transport. And then an overview of the search process and the disciplines used are coming up in the next 2 slides. So the Web of Science Psych articles, PsycInfo, where the web base is used. On initial search, it yielded 345 results. After abstract reviews and full text reviews, final selection then 56 articles were included in the lit review. But this also included 9 articles of grey literature as well. Some of the disciplines used ranged from psychology to gerontology, geriatrics, psychiatry, and of course the aforementioned grey literature. So what did I find from the lit review? Well, many people with cognitive impairments actually anticipate that they will experience difficulty using public transport even before they leave their house. So for example, in Sweden, Asplund and colleagues in 2012, they surveyed over 800 people post-stroke, and it showed that the majority of these individuals did not use public transport after a stroke. Research then conducted in 2010 by Wendell and colleagues found that up to 1/3 of individuals living with some form of cognitive impairment reported a significant decrease in or no usage of at all public transport compared to their usage pre-cognitive impairment. This sense of anticipation may stem from a decreased level of self-confidence, resulting in the reduced uses of public transport and public transport infrastructure. People living with dementia then may choose a variety of different ways to access activities outside of their home, such as walking, cycling, or utilising various forms of public transport, such as taxis, buses, trams, trains, or even driving a motor vehicle. However, driving requires a particular set of skills, and it may be adversely affected by cognitive impairment and a diagnosis associated with a cognitive impairment such as dementia. Public transport, therefore, may allow autonomous outdoor mobility for individuals who can no longer utilise a motor vehicle, which may help to reduce an individual's reliance on support of family, friends, and/or social services to remain actively engaged in the society. And more in recent literature, social participation is being used as an indicator of health and well-being. So therefore, the use of public transport may become the only link to continued societal participation for somebody who is diagnosed with a cognitive impairment, such as dementia. So the qualitative analysis then part of the study, well, to achieve the aims, the qualitative research design was used, combining pertinent literature relating to dementia, driving cessation, and accessibility to public transport, with diary and field notes and interview data from the participants. 5 participants took part, and there were people who were living with a diagnosis of dementia and who were members of the Irish Dementia Working Group, or who were affiliated with the Irish Dementia Working Group or the Alzheimer's Society of Ireland. Travel companions, for example, a spouse, a partner, family, friend, or carer, they also participated where they have supported the person with dementia to plan or make their journeys on public transport. The sample size, although small, it is consistent with similar research in the area. For example, Stahl and Lexel in 2018, they used similar methodology when interviewing 6 participants, which generated in-depth descriptions of participants' experiences. Just an overview of some... Just an overview of some participant characteristics here. To drive, some used to drive, no longer do, and some are still driving. They're from all over Ireland, from rural and urban and semi-rural areas. The ages range from 56 to 77. They were diagnosed with various subtypes of dementia, and they all use public transport frequently. Trains, buses, taxis, all used very, very, very frequently. And these names are pseudonyms, they're not the participants' real names. Materials and settings then, well, I used obviously audio recording equipment and notebooks. All evaluation material, including recorded material, transcribed data, and participant information was stored on password protected files. So the procedure then, the participants took one or more journeys on public transport and recorded their experience of planning and taking these journeys. For example, if participants elected to record a specific journey, a special trip or going on holidays, a standard typical journey they make frequently, or it could have been a combination of two. When a journey was made frequently, we encourage participants to record their experience more than once. If participants took their journeys in the normal fashion, so if they typically traveled alone, they did so in this case, or if they were typically traveled with a spouse, partner, or carer, they did so here too. They then recorded their experience of making the journeys. Now, they had an option to either use like a dictaphone or some sort of recording device, either an Android phone or an iPhone, or they also could keep a written diary or field notes, or via an interview with myself, which lasted for maybe 30 or 45 minutes. Participants themselves selected which they were more comfortable with doing, but where they selected to make an audio or written diary recording, they were made aware that I may wish to conduct a short interview with them post-journey, just about 15 or 20 minutes in case any points needed to be clarified. Interview data then were analysed by applying an inductive qualitative thematic analysis that used open coding to derive themes directly from the narratives, and all participant narratives were used in this study. I mentioned the travel chain earlier, and the reason why I wanted to look at all aspects of the travel chain is because using public transport is not just a simple procedure. It's not just one procedure where you just get on the bus or train or tram. It involves pre-trip planning and pricing. It involves booking a ticket. It involves getting through the transport hub. It involves checking in or boarding on the journey then itself, and then destination and post-trip. So I thought it was important to examine areas all across the travel chain rather than just on the journey itself. So findings then from the participants' transcripts. Well, there was two particular sets of findings: dementia-specific factors and environmental factors. So dementia-specific factors included stigma, stage of condition or level of impairment, sense of autonomy, and sense of unease and discomfort. Whereas environmental factors was the physical environment, the rural-urban divide, transport availability and accessibility, and then greater public awareness. So both dementia-specific and environmental factors acted as either barriers or facilitators to people using public transport. So just some quotes then to back up the dementia-specific factors. So one participant said, yes, there's people that have dementia that they don't want anybody to know. It's a bastard for them. That's solely because of the stigma that goes with it. While another participant said, when I was first diagnosed, I would never take the train on my own. My wife would have to go everywhere with me. But once I got used to it, the staff are more than willing to help. All you have to do is ask them. Someone else said, I can read the timetable. I can work on that. I haven't reached that stage yet. While another participant said, I have taken the train and sometimes I have to stand. The bus is always crowded. I feel awkward. It's difficult for vulnerable people to use busy transportation. So some findings then, or some quotes to back up the environmental factors. So one participant said, there was a big crowd getting off and I didn't see the railings or gate. I was pushed through the gate, missed the curb and fell onto the road. While another said, we live out in the country and our nearest town is 3 miles away. If I had to get a bus in the morning, I would have to get a lift 3 miles into town. There's no link service into town whatsoever. Another participant stated, it had been a long week. I was pretty exhausted getting off the train and I had to do this bit totally on my own. A lot of people got off the train and everybody seemed to be in a hurry. While someone else said, the staff know me. They know I have dementia and they're absolutely wonderful. So in conclusion then, this study does provide an insight into the experiences of people using public transport for people with dementia. Findings shed light on both the personal and environmental factors, as I said, that either act as a barrier or facilitator to public transport use for people living with dementia across all elements of the travel chain. These findings demonstrate that public transport, when and where available, can be used by people with dementia to engage actively in their community. Many individuals with dementia do not require any assistance to navigate the various public transportation systems, mainly due to the stage or severity of the condition. In other words, people who are living with relatively mild cognitive impairment appear more able to access public transport systems. However, for many more individuals with a significant cognitive impairment, they do require assistance due to the hidden nature of dementia, and the lack of public understanding and awareness can act as barriers for these individuals. So just some recommendations then before I finish. Public transport staff and the general public could greatly benefit from training and educational programs, specifically focused on recognizing the signs and understanding the effects of cognitive impairment in order to increase their knowledge about dementia. Training may help reduce the stigma and allow public transport staff to facilitate people with cognitive impairment, such as dementia, thus making public transport hubs more dementia friendly. The anxiety that people with dementia may feel about using public transport may be reduced as a result if public transport staff are more dementia aware. However, this must be a bi-directional relationship. Between the people with dementia and the public transport staff, in order to facilitate the sharing of knowledge in relation to the condition. People with dementia must be involved at every stage of any training or education programs that public transport services may undertake. After all, they are the experts. This in turn may allow people with cognitive impairment, such as dementia, to disclose their condition without the fear of being stigmatized. So that's the end of my presentation, guys. I'd like to thank you all for listening and hope everybody has a lovely evening.
Thank you so much, Cathal. That was very interesting.
Thank you, Kim.
So now I am going to turn it over to Jenna.
Hi, everyone.
Hi, Jenna.
How are we?
Good. I'd just like to introduce Jenna. This is Jenna Pyne. She's a speech and language therapist at the Cope Foundation, and she's going to give us the next talk.
Great. Just going to share. Okay. Hi, everybody. Thank you for the introduction. My name is Jenna Pyne, and I'm presenting today our presentation, Supporting Dementia Care in a Disability Organisation, on behalf of our dementia care team here in Cope Foundation. Cope Foundation, some of you may be familiar with it, is a disability organisation supporting over 2,500 children and adults with intellectual disability and or autism. We're spread across Cork City and County, and we provide residential, day services, respite schools and early intervention services. So just to give you a quick snapshot into what we do. So I'm sure everyone at this stage is very familiar with what dementia is and know that it's an umbrella term for the signs of cognitive decline that impact our daily functioning. But how does dementia relate to intellectual disability specifically? So people with intellectual disabilities, in particular those with Down syndrome, have a higher risk of developing dementia at an earlier age when compared to the general population. Alzheimer's disease is the most common type of dementia for people with Down syndrome, and they actually have a genetic predisposition to this disease. You might be aware that people with Down syndrome have an extra chromosome 21, and this actually carries the amyloid precursor protein that is found in individuals with Alzheimer's disease. Something of note also, which is specifically for those with dementia and Down syndrome, and can be, I suppose, seen as quite a red flag, is the late onset of epilepsy or worsening of existing epilepsy. This is known as late onset myoclonic epilepsy in Down syndrome, which is also actually linked to the chromosome 21 as it resides beside that myoclonus gene. So when we think of dementia, a common sign we might associate with it is memory loss. However, for people with intellectual disability, memory loss is not such a reliable sign. And in fact, the early signs of dementia are far more subtle and can present differently to the general population. This is due to various reasons. Those with intellectual disability already have an impaired cognitive functioning, as we know. 90% of this population can have communication difficulties, and many also present with existing chronic diseases and behaviours which can make it difficult to identify these subtle changes. So when we think of prevalence rates, looking at this graph here and the prevalence rates available to us, we can see here on the broken dotted line on the left-hand side of the graph that people with Down syndrome have a higher risk of developing dementia at an earlier age compared to the general population, with people with Down syndrome presenting with dementia from as early as 30 years of age. It's therefore recommended to assess people with Down syndrome from the age of 35 to establish a baseline of their level of skills and abilities, which can then be used to compare against future suspected changes in functioning. The risk of developing dementia for those with intellectual disability is less than for people with Down syndrome, but it's still between 2 and 3 times greater than the general population. Based on the average onset for people with intellectual disability, screening would be recommended to commence from the age of 50 for the intellectual disability population. So looking at our demographics here in COPE Foundation, and just to give you a sense of where we're coming from, we support approximately 1,500 adults. And then if we look at it with those at-risk categories that we just talked about in mind, for people with Down syndrome and intellectual disability, we actually found that over 1/3 of our adult population is at risk of developing dementia, which is a huge portion of our population here in COPE. So with this significant figure in mind, we looked to the available literature and at international best practice, which recommends the development of care pathways to ensure early detection. It also recommends prompt multidisciplinary team assessment and diagnostic services, including baseline assessment for those with Down syndrome over the age of 35, as we said, and baseline assessments for those with intellectual disability over the age of 50. Furthermore, best practice would recommend a coordinated specialist team dedicated to the care of those with dementia. So here we get a snapshot of fame with a photograph of the team. But our story so far, and I suppose how it all began, back in around 2016, our aging population with their aging parents and carers became very apparent. The multidisciplinary team were receiving increased referrals of a crisis nature relating to dementia, often at that late stage dementia where those early, more subtle signs had just been missed, and it was often too late to provide the care that we may have hoped to. The nature of referrals, just to give you a sense that we were receiving, were primarily relating to loss of skills, eating and swallowing concerns, hydration concerns, and many required 24-hour nursing care and intensive support. In turn, this meant increased pressure on residential settings and day services who just felt they didn't have the expertise and knowledge to provide specialist care to those presenting with dementia due to increased medical needs, change in presentation, as well as behaviours and environmental issues. So with the support of our organisation here in COPE Foundation, an interdisciplinary team consisting of various disciplines from across the organisation was formed. And initially, each discipline was allocated 1 day per week for the team to coordinate and work together to provide dementia-specific care and supports. So the goals of our dementia care team were to provide a proactive screening programme in line with best practice guidelines, to facilitate a standardised response to care as part of a dementia care pathway, to offer a coordinated team approach in the assessment, early diagnosis and quality care of people with dementia throughout the continuum of the disease, to support each person to live at home where appropriate or community of their choosing for as long as possible, to educate and train staff and carers to improve the quality of life and end-of-life care for individuals with dementia. And we also wanted to create a resource to support staff and carers of those who may be at risk of or who have dementia. So in order for us to facilitate a proactive screening protocol and standardized response to person-centered care, a dementia care pathway was developed and adapted for our organization. This pathway, as you can see, and this can be shared at a later stage if anyone would like a copy. As you can see, it has two strands. So a proactive screening strand, whereby screening for individuals with Down syndrome starts from the age of 35, and for those with intellectual disability from the age of 50. Again, all in line with best practice guidelines. On the other strand, reactive screening can take place where a decline in activities of daily living, communication, cognitive or physical ability is noted. You'll see there are clear steps to follow to guide the appropriate course of action and to refer then to the dementia care team as appropriate. So it's just to give you a sense of the pathway that we developed. So then, I suppose in keeping with our pathway, and with a screening protocol in mind for our intellectual disability population, it's important to note, unless a baseline level of functioning and cognitive ability is established when the person is healthy, it's very difficult to detect early signs of dementia later in life. So for the purpose of our screening tool, we initially piloted 2 screening tools. So they were, you can see them here, the adaptive behavior dementia questionnaire and the dementia screening questionnaire for individuals with intellectual disabilities. We found the ABDQ was appropriate for those presenting with a milder intellectual disability, but the DISQUID, as we call it, was found to be that bit more sensitive a tool in screening those with the moderate to severe intellectual disability. I suppose it's just to note the DISQUID and the ABDQ and other screening tools, they're obviously not diagnostic instruments. So we just utilize them to compare changes over time against a baseline measurement of the person's skills. So in line with our pathway then, and I suppose another bit that we created as part of this, when screening indicated a change or concern and where further investigation was warranted, a dementia-specific information checklist was created and should be completed by staff to support a referral. We developed this checklist to look at very specific information to accompany the referral. As people, and we said it earlier, as people with intellectual disability and Down syndrome in particular may present with specific conditions that on the surface they might look like dementia, but in fact they're treatable conditions such as hypothyroidism, I've named a few there, sensory impairments, even the impact of environment and things like that can have a huge impact. So this checklist that we created, and again, I can share it with anyone who might be interested, it helps to exclude these conditions. And it is important to consider these other conditions that may cause loss of skills or cognitive decline, which may be treatable before a diagnosis of dementia can be considered. So this is a huge part of the work that we do. And it works well and accompanies our screening tool nicely. I'm sure you can all appreciate that a misdiagnosis could have pretty serious implications. So this is why we would stress that dementia in the Down syndrome population in particular is a diagnosis of exclusion. So here are some of the team's key activities to date. Support around screening and providing person-centered intervention accounts for a significant proportion of our work, but linking with staff and families on the ground has been invaluable. I suppose just to support that point, here is some of the anecdotal feedback that we've received from staff and caregivers. One that stands out to me is a quote from a clinical nurse manager who works in a residential setting, who provides care to a number of individuals with dementia. So it's just the quote there in the middle. Having the link to advice and knowledge of the dementia care team is invaluable, even just for affirmation that we are doing the right thing. And I think we can all relate to that. Sometimes we're just not sure, we need to sound it out. So a lot of our work is that collaboration and consultation with staff or families. So while we acknowledge there have been some challenges given the rapidly changing needs of this aging population, and it being so resource intensive, there have been many benefits. These include increased awareness and knowledge about dementia in our population across the organisation. Even that genetic link with Down syndrome and Alzheimer's disease that we spoke about at the beginning, a lot of staff didn't actually know that, which was surprising. So even promoting that awareness across the organisation has been huge. And we've also been able to offer a more coordinated approach to dementia care, which fosters those strong links between staff and caregivers of those with or at risk of developing dementia. So our next steps or our aspirations, we endeavour to work as a full-time dementia care team, obviously resources dependent. But we would hope that this would set foundations for an older adult trajectory within our organisation. We hope to continue to drive initiatives that improve the quality of life and service delivery in the area of intellectual disability and dementia. Research would actually indicate that it's the fastest growing population, or it will be the fastest growing population over the next decade. So that population being the aging adult with dementia. We've also been linking with the National Memory Clinic and would actually hope to act as a regional satellite team down here, and hopefully long-term streamline services for people with intellectual disability and dementia across the country. And I suppose finally, reflecting on our goal to create a resource to support staff and caregivers of those who may be at risk of or who have dementia, we since published a book which aims to do just this, and we will be launching this over the coming weeks and hope to promote its distribution. So again, if anyone were interested, it's a nice practical guide to dementia care in this population, so feel free to get in touch. And I will leave you with this quote, and that's a very quick synopsis of what we have done over the last couple of years to try and improve dementia care services in our organisation. Thank you very much.
Thanks so much, Jenna. That was really interesting. And I love that quote. It's very nice. Very nice indeed. So now I'd like to introduce Noelle Clancy. She's a student researcher at the Limerick Institute of Technology. So I will hand over to you, Noelle.
Hi, everybody. And I just want to say thanks to Kim, to Grace, and to Neil for allowing me to present here today. And I know it's coming to the end of the conference, and I'm sure you almost have your heads filled with so much knowledge and information, but I'd love for you maybe just from this presentation take away just an element of hope and positivity for the direction in which dementia care is taking place right now. So without further ado, I shall just go through this very quickly with you. So I'm just going to introduce myself briefly, if you don't mind. I am Noelle Clancy, and I am a student researcher with the Institute of Technology in Limerick. And I'm very lucky to have been selected by CareBright to undertake this piece of research for them. And really what we're looking at is the impact on individuals, families and community around Bruff, the CareBright community in Bruff, in implementing the community-based social care model in dementia. So really, I suppose what I'd hoped to do when I started out doing this research is, along with the findings, not just for the benefit of CareBright themselves, but wouldn't it be amazing if we were able to go forward and use this in the context of the best practice and best care for going into dementia care here in Ireland as well. So the model I had used, that I had looked at, is using qualitative research. And as you know, it is the gathering and analysis of data in order to gain an understanding of a person's lived experience. And in order to do that, I used a method called a narrative inquiry. And the joy of this is it actually just lets me take in the story from the person who's telling it. Essentially, I'm the vessel. I'm only just there to hear the story, and it doesn't matter whether there's any truth or not. The story, in my eyes, the truth was what was being told. So for me then, to be able to go forward with this, it was a case of there's three elements that they look at. It's the relationship in terms of the temporality, the sociality and spatiality, and I call that time, place and people for doing the research. So what we had done then is, I suppose, really, why are we doing this piece of research? Because we know dementia is becoming an issue globally. It's been discussed in terms of being one of the reasons of a leader in causes of death, which very few people talk about. But we know, as some of the previous presenters have spoken about, that it is a syndrome in which there is a deterioration in memory and thinking, behavior, general cognitive ability, and it's caused by diseases of the brain. So in Ireland, we know that there's a figure out there. It's been there for many, many years. It's 55,000. It doesn't seem to have changed, despite the fact that they are looking at the expected diagnosis of people with dementia to increase to 141,000 by 2050. That's a huge amount, when you think of where we're going with diseases and where it's how it increases. And of course, the reason why we're doing this research is it's not just the person that has dementia that is unfortunately affected. It is seen that there are 3 people directly affected for every one person who's living with dementia. And that could be family members, it could be local community, it could be relations, it could be staff members, So why Care Bright? Why did they go into this? Well, they looked at what is out there available for people at the moment. And the majority of people are living with dementia in the home. And the figures that are out there, according to the Alzheimer's Society of Ireland, that 180,000 people have either provided care or are currently providing care to those people in their homes. Or the alternative is to get home help in, to go to nursing homes, to use daycare centres, be they specific to people with dementia or not. Or, there's quite a lot of people that are in long stay hospital care because they can't be discharged because there isn't anything out there for them in the community to be able to support them to live with dementia. So what are we talking about when we talk about a community-based model here in dementia care? So O'Shea in 2016, he looked at this as being a holistic approach to dementia. It's a combination of formal and informal supports. And what does that mean? It can mean anything from the daycare services that go into your GP, your consultants, but also anything that might stimulate or act as an intervention for people who are living with dementia, be it going to therapies or anything like that. But the key to the community-based model is that there is a bespoke dementia training to staff, family and volunteers that allow for the information and awareness of to the wider community of events or just information with regards to dementia itself. And how is this community-based model delivered? Well, it can be done very informally through befriending and community connecting, or it can also be done formally through connecting others who've dementia in some of those formal care settings and through activities that they might undertake. And so we look at what is a social model of care, and really what that does, it actually looks at the person itself. It looks at their emotions and the behaviors of that person with dementia, and we look at them in terms of where they are right now. I suppose the best pointer on that would be looking at their life story, and this is how we get to know that person. We get to know their story, we get to know their background, and that can be used then to provide bespoke care to the person living with dementia, so that it's giving them the ability to live a quality of life that will suit them really. And you know, all of these models, anybody who works in the area of dementia care, they'll know Cathal and his theory of person-centeredness. And really what it is, it literally just places that person at the center of care, you know, and really it is putting all the supports in place that will help them have a good quality of life. So just a little bit about CareBright, and I don't know if anybody has seen, years ago there was At Your Service had done a piece on CareBright where they were looking to set up the actual facility down in Bruff. But what it is, it's a purpose-built site. It was modelled on Hodgeway over in the Netherlands, and Hodgeway, I suppose, would be held as being one of the centres of excellence in terms of delivering a social care model in dementia care for people who are living with dementia. And so CareBright, they went out and they built 3 bungalows with 6 residents in each. It's a beautiful, fantastic facility with a home environment. Essentially the communal areas will be the kitchen and the living area, but everybody does have their own private bedroom and a bathroom that allows, you know, for them to go and take their own time out. The model that they had initially looked at using in CareBright would have been the butterfly model. And when we talk about this, it's feelings matter most, but what it is, actually, it's a model of care that's delivered from top down. Essentially, everybody buys into it, from the top member of staff all the way down to anybody that's going in through the doors, and that would be to do with the staff and the local community and family members as well. And the other area that they have looked at, that they have implemented as well, is the dementia care mapping. And what that is, literally follows a person with dementia and just looks at what it is like to live their life through their eyes. And so essentially what it does then is provides this holistic approach. And the best part about the CareBright facility is that they promote normal activities of daily living. Essentially, people call it a home from home. And while, you know, the people have brought in their own elements of their own homes just to make them feel more settled and more at home. And how they promote these, you know, well-being and quality of life is that they engage the residents in therapies through art, exercise, social activities. It's all done very informally, and people have the choice whether they want to take part or they don't. They also have the benefit of having a public cafe there, so that anybody who's living in CareBright Bruff and the family get to benefit from being able to stroll down to the cafe at the end of the facility. There's also a hairdressing salon there set up for the people who are living with dementia. There's acres of space. You know, I mean, we don't look at just a built environment, but we also look at the environment around in terms of greenery and engaging them in gardening and enjoying that element. There's polytunnels. They have 3 pygmy goats down there for farm animals. And there also is a gym area, a spa area that's being developed as well at the moment. And that will go forward to promoting good quality of life for people living with dementia in Bruff. So I was very lucky that I was allowed to do this piece of research, and I was able to interview 5 residents that live there. I won't go into their actual the breakdown, because I just want to allow for their anonymous contribution here. It's a very small community that lives there, and sometimes by even mentioning male, female, or ages, that I could identify them, so I just won't do that if that's okay with you. There was also 6 family members that were interviewed. I interviewed 4 staff members. All of them, bar one, came from a nursing background or are in a nursing background. And then I got to interview 3 local members of the community who also happen to be volunteers there with the community of CareBright. So as I explored, you know, the impact of living in CareBright for people with dementia and their family and the people who worked there, if you just look down through the reasons for moving to CareBright, I mean, all of these speaks to anybody who's got somebody, and for people who are living with dementia, you know, the lack of supports, both in the home and in the community. Personal safety, you know, the need for company, I suppose, and stimulation and socialization. There was also things, you know, geographical distance, and sadly, you know, there's family dynamics, and there was relationships that have been affected by having a diagnosis with dementia. So these led to considering moving to CareBright, and ultimately for people moving into CareBright. So in terms of my findings, you know, I did the thematic analysis, and there was coding involved as well. So I came up with these quite prominent themes that emerged as I was going through, and these were regular ones. There was, you know, their quality of life. No one reported any decline in their quality of life, and in fact many reported an improvement, and this would have come across the board from everybody that participated, be the people living with dementia or their family members or the staff. Their basic needs were met, and if you were to think of, you know, Maslow's hierarchy of needs, there's quality accommodation, there's nutrition, all their needs were met in terms of that, and above and beyond. In fact, their physical health was always being monitored, and was, you know, they were quite conscious of their mental health there as well, in terms of people coming in that might have been distressed or, you know, experiencing stress and depression through their diagnosis of dementia, or it could have been indeed any other element of it as well. But there was a wonderful autonomy. There was a freedom of choice. You know, people did feel they had a choice. Some people might say, well, you know, we're forced to do this, but actually they will admit afterwards that there was a freedom of choice in doing activities or going places. There was a great promotion of activities of daily living, and it was wonderful to see some people talking about old hobbies relearned. And what I thought was interesting was there was new hobbies taken up. And for me, that demonstrated plasticity across the lifespan. You know, it goes to show that no matter what, people always have the capacity to learn, even though people with dementia, it would be one of the areas where they feel they mightn't be able to progress so much. But, you know, where they would have the time now and the space to drop old interests. You know, some people spoke about the fact that they've done gardening all their life and they never wanted to do it again. And they want to take up new ones where people have gone and done artwork or learning how to do yoga and other activities like that. Some of the other heartening things was that people had a sense of purpose there. Some people who were living there with dementia, they were actually working for CareBright. They genuinely had a purpose there. It wasn't tokenistic in any shape or form, that they actually were given a job to do and they got paid to do it. And other areas who may not have gotten paid, you know, people were knitting for charity. There was a purpose to the knitting. It wasn't just for the sake of sitting down and being sociable about it. They actually made it into a goal and a purpose. One of the huge areas was security. Everybody spoke about how there was a need for security, and that maybe they hadn't felt it when they were living in their own home. And for this, it meant many things to people. Security was, you know, physical and mental safety. They were in a confined area. There was barriers around for some people who thought that maybe if there was a risk of abscondment, at least barriers were there. But in fact, you know, that wasn't one of the biggest considerations of fear for the people or staff of CareBright. You know, behind every action there's an action. So for somebody who was, you know, looking to get out, they looked to see what that need was, and they tried to meet it as much as they could. It also provided a peace of mind, and the notion of surveillance was there as well, that they knew that if they were to fall, there was somebody around to get them, maybe not immediately, but they would be there, or they were within sight of other people. One of the other areas, I suppose, that impacted, you know, families and people living with dementias was the relationships. And there was quite a significant experience in the shift of relationships. For some, there was a breakdown between siblings, going because of the move to CareBright. For others, there was the loss of the parental and child relationship because it was no longer there. And that led, you know, to looking at grief and loss, which I'll look at in a minute. And also, but what was fabulous was there was new friends made. You know, people thought they no longer had the capacity to make new friends, that they were beyond it, you know, as we look at disengagement theory through the sociological lens. But no, there was very strong, I suppose, solidarity was created through their living there. They had shared experiences, and I could definitely see that there was a promotion of resilience. People were able to get up and move on with themselves, you know, and it also reduced stress and depression for people having these connections. But I'll go back to the grief and loss. You know, ambiguous loss is a big thing for people because, as it's described by Boss, it's physically present but psychologically absent. So I suppose, you know, one of the most poignant quotes that I'm going to use here was Paul spoke about, now I suppose I no longer get direct happiness from my dad, but he did acknowledge that he got it hearing about his dad being happy. So it was quite nice. I just move on there to the provision of care it was entirely focused on the people and their families. And it was the attitude and support of staff. It wasn't always seen as staff, it was more of friends, which was a huge element of looking at person-centred care. You know, and also through the fact that there was care plans and life stories in place. And also for a lot of people, it was very reassuring to know that there was an end of life care plan there, that they wouldn't have to move out of the facility in Carebright. But one of the things across the board that was negatively mentioned by all is the financial impact. And we know that dementia care is quite costly. And unfortunately with Carebright, it's no different. There was a cost implication to the families and to the running of Carebright, and also to developing the model. But indeed, you know, these are all things that there's very little control over at the moment, and it would be something that would be interesting to explore further. I know people have looked at it as well. So just to conclude with our wonderful story that I got from all the people that told me their stories, that all the participants were very positive about the model and how it was being delivered. The staff, the family and the community involvement, it's key to promoting this model, and that's again the holistic aspect of it. And all participants understood that the model was evolving. It's quite a new model in Ireland. It's a first of its kind. It has to be known, and it's great to be able to look at this kind of model. You know, nothing is going to be perfect from start. I suppose where I could see the room for improvement was the financial aspect. It is costly and it is prohibitive for some people to be able to go to Carebright and live there. I suppose even though they do it, there is a need for continuous awareness of the services to the immediate and greater community. Now they are doing that also through daycare services, and you know the cafe is open, so that is certainly expanding. And you know, always bear in mind that dementia never stops in its tracks, and that they acknowledge this, and they are doing it, that there's a continuous training for not just the staff but to volunteers and family members as well. It's very important that everybody keeps up to date on what's happening in the best way, you know, maybe for acknowledging symptoms and working with people with dementia. And I suppose the last thing I would just bring up would be consider barriers of communication. For some people, they might be very shy about bringing back feedback, even though it's a very open door policy, always is, and there's always somebody around to talk to. But I suppose really in terms of formalizing that communication, that maybe to consider that there is another way of looking forward to getting a feedback from the stakeholders that are involved. So that is it. That's my little piece that I've done in my research. It's just been a genuine joy. I loved doing it, and there's a lot to be learned from it. I can't wait to share it when I finally finish writing my pieces.
Thank you so much, Noelle. That was really interesting. And yeah, it's very joyful topic, I can tell.
Yeah, it was really interesting.
So just having the rest of the panel come back. Very good. So we have received one question. So any questions, if you guys can put them in the Q&A or the chat. So we've got a question for Jenna. The booklet that you spoke about, A Guide to Dementia Care for People with Down Syndrome and ID, can we download this, or where can it be found?
Perfect. So the book, I have it here. It's not downloadable, unfortunately. We have it ISBN registered, so we will be selling it for a fee of around €20. We're launching it on the 17th of November as part of a masterclass with the National Memory Clinic. People are more than welcome to sign up to that via the Trinity College website, tcd.ie, the research link. I can try and find a link. Alternatively, please take my email address, which I can call out, and if people want to contact me directly, we can provide you with the book now. But it's not available yet to buy on a website, but we will. I suppose the goal is to get it on the Cope Foundation website. So I'll just call out my email address if that's a help to people. It's PyneJ, so PYNEJ @cope-foundation.ie. So feel free to contact me if anyone wants a copy. A burning desire to get a copy, we'd be happy to provide that. So thank you.
Wonderful, thanks very much. Then we just have some lovely comments in the chat. So while people are thinking if they've got any other questions, I'm just going to quick launch a poll for the attendees to give us some feedback. So I thought that was really interesting and a great way to end up the conference, guys. Really enjoyed that.
Thank you.
Our pleasure. Well, mine anyway.
A collective hour.
Exactly. No, you can tell that you're all very passionate about what you were talking about, and that made it really interesting at
Good.
this late part of the afternoon.
Yeah,
So that was very good of you.
we're grateful for people sticking in there. So
Exactly. And this will be recorded and put online, so there'll be a bigger audience out there in the near future.
Wonderful.
super.
Great. So I don't see any additional questions. So thanks so much again, and really enjoyed the speakers. And thanks everybody who attended this session and others during the conference. Thank you so much.
Thank you.
Okay,
Thank you.
guys.
Thanks,
Thanks,
guys.
Kim. Have a good evening, everybody.
Well
You
done.
too.
Take care, Cathal.
Bye.
Take care,
Bye,
Jenna.
bye,
Thank
bye, bye.
you.
Thanks,
Take
Kim.
care.